Okay. And here we are, Dr. Amy Killen. What a treat.
Hi, I'm excited to be here.
Yeah, I've been following your work and a big fan. So thanks for everything that you're doing, all your clear, concise communication with the world in a time that really needs it. So thank you.
Thank you.
And, I'm excited to jump into all things HT and black box warnings and vaginal estrogen and all these topics that bounce around my household actually quite often, more than you'd even think. But first, I want to ask you about a video that you posted a couple of weeks ago. So this was a video around. It's the best way to describe it is on how many people in the wellness community have been kind of Trojan horsed by the MAHA movement. And this video was subsequently reposted by the great senator of New Jersey, Cory Booker. And I think this thing has now millions and millions and millions of views. So I want to ask you, what's wrong with a cane sugar Coca-Cola or a dye-less Skittle?
I just think it doesn't make a real difference. I think that if we want to focus on health, we need to be much more big picture. And there's so many things that we should be worried about more than whether our Skittles has red dye. You could always avoid the Skittles if you're worried about the red dye, but you can't avoid the air pollution and the water pollution and the soil pollution and all the other things that are kind of happening behind the scenes. So I think that we just kind of got played a little bit.
Yeah, I mean, when I look around at healthy people, they generally don't eat Skittles or Fruit Loops or drink Coke or eat French fries, even if they are fried in beef tallow. To me, while I actually support the work of a lot of the proponents to get chemical additives out of our food system, right? There's nothing wrong with that. It, in many cases, seems to obscure something more nefarious at play and some sanitizing a little bit of like what's going on, for example, at the EPA.
Yes.
So
Yeah.
and I know you've been outspoken about that. I mean, right now, I don't know if you've followed this one particular issue that seems to be bouncing around the internet with this Section 453 of the appropriations bill that seems to grant blanket immunity to the producers of various pesticides like glyphosate and paraquat. And
Yep.
this was passed through a Republican subcommittee totally along party lines. So all Republicans voted yay, all Democrats voted nay. And, I've pointed out to many of my friends kind of in the MAHA world that this is kind of the product of the bargain that was made. And sometimes that falls on deaf ears. I wonder kind of what you think about that.
Yeah. Yeah. I feel like that the environment really should be nonpartisan. Like, I don't understand, I actually consider myself pretty centrist, even though I don't come
Yeah.
across that way necessarily. But I worry so much about the choices that are being made by the higher ups, sort of trading dollars for environmental health letting the big businesses buy their way out of having to comply with the rules now. And it's sad and it's scary. And I think that health it's reliant on us being vigilant about our environment.
Yeah, 100%. I think, there's very little separating human health from planetary health, but they often get seen very separately and certainly treated from a governmental policy perspective very separately. And I think where the friction is right now, and I think we're going to see this bubbling up more and more. And just to frame this, I'm also quite centrist myself, but that conservatives are generally kind of anti-regulatory. They believe in the free market, they believe in maximizing, shareholder value and corporate profits, et cetera. So that's
Yeah.
one side, and progressive tends to be like highly regulatory minded. They believe that government actually has a role in regulating industry to kind of dull the sharper edges of capitalism, if you will. And those are just ideological differences. But to properly MAHA, if you will, you need a regulatory mindset. And I think that this is where the friction is going to happen, anyhow.
Yeah, I think that we know we cannot rely on businesses to police themselves. Like we've seen this. It's not a surprise that they want to make money and cut corners, and that they will do that whenever they can. So I do think whether you believe in big government or not, in some cases we do need to step in and make sure that the rules are being followed.
Yeah, 100%. So, in defense of HHS, potentially, actually, I want to get your viewpoint on this. The FDA chair, Marty McCary, just hosted a public hearing focused on menopause. And a lot of the topics that were addressed were around black box warnings and vaginal estrogen. In some ways, kind of addressing some of the vestiges of the WHI from 2002. So I assume that you must have followed these hearings, and I'm curious to get some of your high level thoughts on
Yeah,
what you saw.
I'm very. I mean, it's overdue, and I'm very excited that this happened finally. I think that I really do think finally that box warning will get taken off of vaginal estrogen. We've been talking about it for years, but we know it's completely safe for basically everyone, and the warning that it gives you breast cancer and heart disease and dementia is completely wrong. So I'm excited. I do think that that is a positive thing, and I'm happy that the conversations around testosterone for women and just the general messaging around hormone therapy and how that it's actually probably more beneficial than not is finally maybe getting out there a little bit more. I think in the last few years we've seen that in social media, and so to see it in front of the FDA and hopefully to go even wider with that message is I think it's progress.
Yeah, I mean, for folks that aren't aware of the black box warning and how it developed and out of this women's health initiative that happened kind of back in the late 90s and then early 2000s, what was wrong with that study, and how did it lead to information that really suppressed the adoption of hormone therapy?
So the Women's Health Initiative came out in 2002, and it was, essentially it was the wrong hormones being studied in the wrong population of women. So we were using synthetic estrogens, synthetic progestins, and then we were using them in women who were at an average age of 63. So they'd already been, 13 years on average from menopause onset. So you have older women. So it was the wrong hormones, wrong population of women, and they essentially released their results to the media before they even had them published and peer reviewed. So they essentially came out to the media, they stopped the study, they said, oh my gosh, these hormones cause breast cancer and blood clots and heart disease and strokes. We got to get everyone off of them. And they hadn't even gone through the peer review process, which we know is really important for studies. And so in the last 20 years, we've realized that, that they did some things that weren't ideal. We know how to do it better. We use the proper hormones. We use the early start if possible. But unfortunately, the fear that came out of that study it's still around today. Doctors are afraid, women are afraid. And so, less than 5% of women over age 50 are currently taking hormone therapy, even though we know it's super beneficial.
Yeah. When you say synthetic hormones, is that a delineation between synthetic and bioidentical hormones? Can you just untangle that a tiny bit?
Yeah, it's not, I think it's kind of a misnomer, but yeah, in my mind, or kind of the way it's talked about is synthetic is the non-bioidentical version of hormones. So bioidentical just means the chemical structure of the hormone matches what your body would make. So estradiol is the estrogen that we all make, testosterone is the testosterone, versus the synthetic form, which is like, for instance, estrogen. It's derived from pregnant horses' urine, and it's a very different looking molecule, and it behaves differently in the body. Although it does bind the estrogen receptors, there are a lot of other kind of effects that are different than the estrogens that we make. So it's just bioidentical versus kind of non-bioidentical is the synthetic version.
Mm-hmm. Okay. And how do women know whether or not hormone therapy is right for them? Are there blood panels that one gets? Because I don't know, because day to day it would, in my mind, and I don't know, you'll help me understand this, levels would vary. So how do you really know? So, for women that want to untangle whether or not it's right for them, how do they do that?
Well, in menopause, so once you've gone, 12 months without a period, you're officially in menopause. In menopause, your hormones are very low and flat. So it's pretty easy. Your ovaries have shut down. You're not making estrogen and progesterone in any significant way anymore. And so in that population, it's just about, kind of where you are. We could put you on hormones without even checking levels, although I do like to check levels because we know you're low. In perimenopause, which is, up to 10 years before menopause, so it can start as early as 35-ish, your hormones are pretty erratic during that time. And so we go generally based more on symptoms than we do hormone levels, but I still will check hormones, just to kind of get a baseline, but estrogen and progesterone are fairly erratic during that time.
Hmm. Okay. So my wife went through menopause, and she has a kind of a transdermal estradiol patch that she wears. But that's different from an absorption perspective from like vaginal estradiol, right? Am I understanding that right? And can you kind of differentiate or delineate between the two? And then I know that in these recent hearings, there was a lot of focus on vaginal estradiol for various purposes and also because it's non-systemic. So help us understand all of
Yeah.
that.
So when we talk about vaginal estradiol, usually we're talking about this low dose vaginal estrogen. So, and the dose is important because if you put something in the vagina, if it's a high enough dose, it will get into the rest of the body. Just like if you put a patch on your skin, if it's a high enough dose, it will get in through the bloodstream and the rest of your body. So it's more about the dose than where we're putting it. But the dose that we give vaginally for just pelvic floor health is about a tenth or less than the dose we're giving, for like general health. So essentially, we're giving 0.1 milligrams vaginally versus more like 1 milligram if you gave a cream in the skin. So what that means is that the vaginal estrogen is just staying there in the pelvic floor. It's working in the vagina, the vulva, in the bladder, the muscles down there to keep all of that healthy as you get older. And it's not getting into the rest of the body and causing changes in estrogen levels in your blood.
Got it. Okay. And what are the different methods of delivery for vaginal estradiol?
So vaginal, it can be a cream. The most common one is just a cream that you can get. It's a pharmaceutical product, and it's you can get it for like $13 on Costco or on one of the discount drug forms, but you do have to get a prescription. But there are creams, there's suppositories, there's rings, there's all different various pharmaceutical products, and you can also get it compounded if you prefer, if you don't want the dyes or the fillers or things like that in there. So you have lots of options, but unfortunately, it is still a prescription. So you still have to have a doctor that knows about it and that will write you that prescription.
Is there a preferred method in your opinion?
I think my favorite way I think either just just the prescription estradiol cream, which is a 0.01% cream. It's very inexpensive. Estrace is one of the names of that. That's the most inexpensive way. I also really like a compounded cream with what's called an allage anhydrous base. It's essentially like it's a base that doesn't have any gluten or soy or fillers or dyes, or like it's a very clean base. And it also has these properties where it stays inside of you better. It adheres to the vaginal wall. So that's a nice option if you can get it compounded.
Do you have to go to a compound pharmacist for that?
Yeah, it has to be compounded at the
Yeah.
pharmacy.
Got it. Okay. And what are some of the symptoms that vaginal estradiol addresses?
So anything related to low estrogen in the pelvic floor. So for instance, vaginal dryness, pain as you get older and your vagina starts to thin. So sex is painful. UTI, so recurring bladder infections is very common after you have a low estrogen because you actually are changing the microbiome in the vagina becomes sort of this bad microbiome, and these bugs are not very helpful in preventing invasion from other bugs. So you get yeast infections, you get UTIs, and this estrogen can help with that. It can also even help with stress urinary incontinence or incontinence, like bladder leakage that can happen as you get older when those muscles start to become like less strong. So it's really helping across the board with pelvic health for women, and it's super easy, super safe, and very cheap.
And is there any age that women should be looking at vaginal estradiol? I mean, is this kind of even going into perimenopause, or when's the best kind of time period in a woman's
Yeah,
phase?
perimenopause is certainly towards the end of perimenopause, your estrogen has kind of come down, down, down. And that's a great time to start low-dose vaginal estrogen. Certainly if you're in menopause, and you can start at any age. You can be 50, you could be 70, you could be 95 years old. And so it's safe, you can start it and it's effective. And then also think about it for women who just have low estrogen for other reasons, like maybe you're breastfeeding for 2 or 3 years and you're not getting enough estrogen in the pelvic floor, or maybe you aren't having cycles because you're overtraining, or you have an eating disorder, or something is happening where you're not cycling. All of that those are all low estrogen states. And so you can add back estrogen to the pelvic floor. It could be really helpful.
Great. You put out an interesting Substack article today talking about vaginal estradiol, and you made a comparison that I'd never heard before between vaginal estradiol for women and Viagra for men. How does that comparison hold up?
Yeah, they're actually very similar in the way that they work. Obviously, there's some differences, but both estrogen and Viagra, the PDE5 inhibitors like Viagra, they're both going to increase blood flow. So increasing blood flow both acutely and kind of over time by helping to keep the blood vessels healthy. They're also both going to support the tissues in the pelvic floor. So you may not know this, but Viagra actually helps to keep the cells in the penis healthy over time. So it doesn't just increase blood flow. It's actually really beneficial for the sexual organs. Same thing with estrogen for women. Estrogen is helpful for keeping the organs healthy as well. And both of them, if given systemically, potentially have both brain benefits and heart cardioprotective benefits. And we've seen that in some of the literature on the PDE5 inhibitors for men, and dementia risk and heart disease risk going down. And then, certainly we know with estrogen, that systemic estrogen is extremely good for women's cardiovascular health.
Yeah, well, so let's hover over that for a moment, because I think one of the things, or the misconceptions that came out of the WHI, was that there was an increased risk of breast cancer, and then also an increased rate of cardiovascular disease, which really kind of flies in the face of everything that I had heard about estrogen and its protective, components or its protectiveness for cardiovascular disease. So, how did that data emerge from that study, and how was it misconceived?
So the breast cancer piece it turned out it wasn't the estrogen that caused an increase in breast cancer. It was the progestin, the synthetic progestin called medroxyprogesterone acetate, which is not one that most of us use anymore. That caused a slight increased risk of breast cancer. I mean, it really ended up being just a couple of extra people per 10,000 woman years. Like, it wasn't even a very big difference, but it was a slight increased risk. However, the estrogen, when you use estrogen alone in that study, resulted in a 29% reduced risk of breast cancer. So again, if they'd waited a little while to publish their results, get a peer review before the media statement, we would have caught that. So that was one thing. And then for the heart disease, it has to do with using a synthetic estrogen and starting it late in menopause. So, when women lose their estrogen at menopause, estrogen drops, you kind of have this invisible shield that was protecting your cardiovascular system. It's gone away now. And so all of a sudden your plaque builds up in your arteries, you get atherosclerosis, and it happens, pretty quickly after you lose estrogen. And so those women in the WHI, they were 13 years out from menopause onset. So they had plaque in their blood vessels. And then we gave them an estrogen, this Premarin, which actually has some activity that ends up breaking up the plaque a little bit, which we know then can increase stroke risk and heart attack risk. It increases something called MMP, an enzyme. So essentially, wrong hormones, wrong population of women.
Mm-hmm. Got it. So let's talk about testosterone for a moment. When is it appropriate for women to consider testosterone supplementation? And am I right in saying that there is no currently approved testosterone for women at this juncture?
Yeah, in the US, there is no FDA approved testosterone. And, so we have to kind of use it off label. We could write it certainly, but we have to use it off label. And, testosterone is different than estrogen and progesterone in women. It starts high at about age 20, 25, just like in men. And it just starts to kind of slowly go down over time. It doesn't like fall off a cliff at menopause. It just kind of slowly goes down. But oftentimes women, maybe in their 40s, could be earlier, it could be later, will have some symptoms of low testosterone. Like classic symptoms are things like difficulty, low arousal, difficulty with libido, difficulty forming muscle, burning fat, lack of motivation to do things. And so those are some classic symptoms. And if you have those symptoms, you can get your testosterone checked. And as long as it's not high, it turns out that oftentimes testosterone is helpful, especially for the sexual side effects. So you could be 30 years old, you could be 50 or 60 years old, but if you need it, then it can be really helpful.
Got it. And should women worry about presentation of secondary sexual characteristics like facial hair and stuff like that with testosterone?
I mean, yeah, you definitely should know it's possible if you get too much testosterone. So we have to be careful and not take a large amount. We don't want to be dosing you. Men have about 10 times more testosterone than women do. So our doses are much smaller. We want to generally stay within kind of that normal physiologic reference range for women. And I will say that, I've had not myself personally, but I've had some like singers, female singers reach out to me on social media that they take testosterone and no one warned them that you could have a little bit of deepening of the voice. And that's one side effect from testosterone that doesn't go away all the time. So that's something that's pretty important. If you're a singer, you should be careful of that.
Yeah, a soprano will become an alto all of a sudden.
Yeah. Exactly.
Well, I'd love to talk just more generally about longevity and your key protocols for longevity. I think you're very interesting insofar that you kind of straddle both medicine and traditional Western medicine, and then wellness as well, and kind of many of the protocols that are associated with wellness. Like I've seen you in a cold plunge, and I'm sure sauna and sun exposure and resistance training and all these things. So, what's your approach to longevity, particularly as it relates to female longevity?
Yeah, I am kind of in the middle of both worlds. I try to pull from what I think is the best of both kind of allopathic medicine and integrative medicine or biohacking, whatever we're calling it. I think the main things for women are probably the main things for men as well, especially as we get older. Building muscle is one of the most important things. And, I have a hard time. I've always been kind of skinny. And as I get older, I'm 49, as I get older, it just gets harder and harder. You got to put more time in, but that is something that's definitely worth doing. So building muscle, I think, is important. Another big one for me is just getting outside and like getting out in nature. I live in Utah, so I'm right on the side of a mountain, so I can go out and go on a hike. But that I find that for the mental benefits as well as physical benefits, that the time in nature, a little bit of sun, talking to the bears and mountain lions it does wonders for me. those are, and then sleep is the other thing that I really focus on with myself. I was an ER doctor for 10 years before all of this. I quit in 2013, but I went 15 years or more really without sleeping much. And then I had twins and, just a whole series of things where my sleep was messed up. And when I started sleeping after I left the ER, like it was amazing. All of a sudden I lost weight, like in a good way. The inflammation went down. I just looked like a different person. And so I really credit sleep with a lot of that as well. So I prioritize that for sure.
Yeah, there's certainly a muscle-centric medicine movement happening now, particularly for women. There's a lot of prominent doctors that have I think, really come forth. They've written there's a number of books out about muscle-centric medicine. For you, does that mean, a regular resistance training protocol? And, also there's a lot of talk about protein consumption that's going on right now too. I mean, are you in that sort of 1 gram per pound of ideal body weight camp, or what's the Amy Killen recipe here?
Well, I mean, first of all, I won't say that I'm perfect in any of this, but I do resistance training. I have a tonal machine at home and I love it. So I'll do that. I try to do that like 4 days a week. So I do weight training, and then I try to make sure I'm doing some kind of high intensity something, whether that's steep hiking or jogging or whatever, and then just a lot of walking. So I do that, and then I don't do as much protein personally as I probably should, and I suspect that's maybe part of why I have a hard time building muscle. But I have a very hard time getting that much protein. I don't tend to be that hungry in general, so I have to kind of force myself to eat. But I also probably think we've overshot a little bit on the protein. Like I don't necessarily think that most people need that much protein in order to be healthy and to build muscle, unless you have like very specific, bodybuilding goals. I think we could probably swing that pendulum back a little bit to be more reasonable.
Yeah, I agree. I mean, I think these trends pop up kind of within the wellness sphere. And, this one was a big one, like a gram per pound of ideal body weight. So I'm like, okay, how does Jeff get 162 grams
Right.
of protein per day? And it's hard. You have to have, a bolus of 50 grams of protein when you wake up in the morning. It's like,
Yeah.
it can become sort of the central focus of your life to try to get that much protein. So I think you're right. I mean, these things operate on a pendulum, and we sort of pendulate slightly back towards the middle. But that I think the generally the information around changing your kind of macronutrient proportion or the consumption of macronutrients more towards protein and away towards carbohydrates, for example, is a fairly good
Yeah.
positive trend.
Yeah.
So I'm curious what you think about some of the sort of eustress adversity mimetic protocols that I think really initially gained a lot of steam kind of in the male biohacking world, but now have come under a kind of more of a microscopic lens as they pertain to women. So I'm talking like about cold water therapy specifically, or fasting protocols specifically. Are those protocols that you adopt personally that you would recommend for women, and how would you delineate between men and women in those protocols?
Yeah, I do like cold plunging, although I will caveat that I like doing it not in the winter because I did a month every day in the winter here in Utah for several years ago, and I was like,
Man.
and I realized I never like it would take me half the day to get warm afterwards. Like I did not, my body was not getting warm, and I do think it was too stressful for me. But I do like it the rest of the year. Like I think it feels great. I love the mental part of it. Like I feel tough. I think there's some definite nervous system benefits to it. But even when we look at the literature on cold plunging, even for men, most of the studies that are, especially the ones for post workout and reducing DOMs and things like that, most of those are actually with 50 to 60 degree water, like, and for like 10 minutes. Like those are not this 35-degree water for 3 to 5 minutes where we're actually seeing the benefits in general. It's kind of that medium coldness range, which I think is fine for women as well. I don't know that we have a lot of data on that, but I do think that that kind of medium range, which really works better for men, also is appropriate for women if we want to do it.
Mm-hmm. And what about fasting?
Fasting, I don't fast myself. I don't eat while I'm sleeping, obviously, but I don't fast because for me personally, I have a hard enough time, again, building muscle, and I want to make sure that I need to keep those calories coming. I think it's if you're fasting and it's helping you to reduce calories and or choose healthier foods, that's great. I think that there are probably some benefits to fasting, but I don't think that they're as haven't seen as good information on the benefits of fasting as I wanted to. A lot of it's kind of mechanistic data, and I'm not really sure how that translates into our human experience.
Mm-hmm. Yeah, one thing that I found about my own cold water therapy protocol was that, yeah, there were a lot of physiological benefits, some that I could actually see quite quickly, but that the most potent aspect of it was actually psychological for me. That I built a certain kind of psychological or emotional resilience that was actually more useful out of the plunge than in
Yes.
the plunge. And I think this speaks to kind of building a greater degree of psychological resilience or psychological immunity,
Yeah.
if you will. And you've become a very, very public person. So, and if you put yourself out in the public, you are bound to, have to absorb some criticism and recrimination and insult, et cetera. I wonder if you find that some of that psychological resilience that you build kind of in these physiological practices actually spills over and makes you a little more stoic in the public spotlight.
That's a great. I mean, I'm first of all, I'm not that public, but I get hate from anyone else for sure. And I think that what's really helped me is just telling myself like I can step away, like I can put my phone down. Like that is not my real life is what's happening here in my family with my kids and my friends, and whatever's happening in my phone or on my computer, like that is not actually something that I have to be a part of if I don't want to. But to your question, I totally agree with you about the cold plunges and the fact that it can help like in your real life. I have a very specific memory from last year. Because I'd been doing this cold plunge every day for during the winter, and the breathing, and it was freezing and it was hard. But one day after that, I was driving home from the mountains from Park City with my kids. It was just me and the kids in my Tesla, and this huge snowstorm hit. And we're in the middle of the canyon and we're driving home, and it was super sketchy. All the cars are, they're skidding out. People are getting crashes. And I found myself kind of in that like breathing mode that I would get into in the cold plunge, like this very slow, kind of methodical breathing without even realizing it. And I was doing that all the way down the mountain before I realized that like this is my cold plunge breathing. And I feel like that's like kind of what got me down that mountain, because it was awful, but I was able to breathe through it. So I do think that that is true.
And your kids were probably like, Mom, what the heck are you doing?
Why aren't you talking to us?
Yeah. Well, I certainly want to respect your private life, but I'm wondering if you are influential on your children in terms of your health protocols and your approach to health. And I ask you from kind of my own personal experience of my children never listen to me, but I'm finding that they rarely fail to imitate me. I'll sneak into their room to, collect 40 dirty dishes, and, I'll notice that there's a meditation app on their phone, and I'll kind of, feel a small
Yeah.
sense of achievement there. So I wonder for fellow parents who are trying to raise healthy children, do you have any advice there? Because we want our advice to be explicit often,
Yeah.
but sometimes it just doesn't work that way, at least for me.
No, I mean, my kids definitely do not listen to me when it comes to eating. They eat whatever they want. And that's, but I also try not to give them like any kind of weird, aversions to foods. I pass along my information. They follow me on social media. They comment, they know what I'm saying. I do think that when it comes to like physical activity and, going and being active and choosing outdoor activities and things like that, they have followed kind of my husband and I, and they're always out doing mountain biking or skateboarding or playing volleyball outside. So at least some of that has rubbed off on them, but probably the diet not so much.
Oh, they'll get there. Speaking of diet, there was one post that you made recently that spoke personally to me about alcohol consumption in middle age. Your post was more specifically about women and alcohol consumption, but to speak for the Y chromosome here, we're having the same issue. Maybe for different hormonal reasons, I'm not sure, but my ability, or my liver's ability to process ethanol seems to be diminishing by the day, and it's really changed the way that I live, because I'm just simply can't get away with being a social drinker at all, and maybe that's good for me. But what's going on, with women, and can you have that occasional glass of wine and be okay?
Yeah, I mean, I still drink occasionally, and I do understand it's poison, but I also enjoy the social aspect of it, and I kind of just try to be careful. But several things are happening. Are your liver, and I don't know if this is true for men, I didn't look it up, but the alcohol dehydrogenase, the enzyme that breaks down liver, starts to work less efficiently as we get older. So that's one part of it. We also, and this part's true for men, as we lose muscle and we gain fat, we're actually losing body water, because muscle holds a lot of body water. And so your amount of total body water goes down. And so when you drink, it becomes more concentrated in your body. Like even, same glass of wine is more concentrated in your body. So you may feel it more because of that, and because the liver is also slower to act. So there are several things going on, as well as some responses in the brain, some dopamine changes and such in the brain that just make it not as pleasant, I think, for a lot of us as we get older to drink.
Yet another reason to build more muscle.
That is, then you can drink more.
That's not one that I've generally seen bullet pointed, but I might add it. You're right. I think that there's a lot of data that has come out recently that no amount of alcohol is good for you, right? There used to be the sort of this blue zone myth that seems somewhat apocryphal now, that, oh yeah, look at these cultures with the highest prevalence of centenarians. They're having a glass of wine every night, et cetera. A glass of red wine could be good for you. of
Right.
course, then even preceding that, there was the resveratrol myth.
The same as all, yeah.
Yeah. And now it seems to be fairly settled science that no amount of alcohol is good for you. And I've actually sparred with some folks politely and on social media about this because for me, yeah, the social aspect of having a glass of wine and the inhibition that comes with that actually enhances my social connections and some people will come back at me and say, well, you got to find some other way, Jeff, to be less inhibited or whatever. I get it, but this is a balancing act, right, between knowing, yes, that this is a carcinogen and it's toxic, and yet we know that social bonds and social connections are absolutely key to health and longevity. In fact, I've seen some people argue that they're the number one determinant for health. Yeah.
Yeah.
So you're walking that tightrope, I guess.
Yeah, I think that that's such a good point. I think that certainly a lot of people don't drink and they're social and they're very happy and that they have no problem. But if not drinking, is going to prevent you from going out with your friends and doing fun things, then I mean, there's a lot you could say about that, but I do feel like the social part is important. Whether hopefully you don't have to drink, but I think that we don't want to alienate ourselves from other people. We've all been in our houses too long, on our phones too much. Like we really do want to be more social if we want to stay healthy.
Hmm. Yeah, I'm curious, how do you manage your social life? I mean, do you schedule social interaction into your life? I mean, you're a busy professional. You're raising 3 kids. Do you actually put it in your Google Cal, like time for Amy to socialize here, or do you make a kind of special point of like getting out for cultural events or community events?
I travel a fair amount for work. So at least, once a month or so, I'm going to like a conference. I know you and I have some coming up together where that's pretty social. Like we're out with other people and doing things. And when I'm home, I do try to see friends at least once a week, just go to dinner or go for a walk or something. Of course, I have my husband and kids are also my best friends. So I feel like it's pretty social just with our family. But I find sometimes if I'm on my computer for several days at a time, then I do feel like I just need to get out and put it away and go see some friends and like be normal because it is so important. I feel so much better once I do those things.
Yeah, there's this emerging field of study called sociogenomics. I'm not sure there's a ton of data on this yet, but the idea is that your social connections actually influence your gene expression on an epigenetic level. So they will turn genes on or off based around social connection. I've seen this kind of pop up here and there. And again, I don't know if there's a lot of data on there, but if you go back and look at how our species evolved over hundreds of thousands of years on the Serengeti and for millions of years as hominids before that, we evolved in communal settings, right? So I think I interviewed this guy, Gabor Mate, if you're familiar with him. He's a trauma-informed therapist. And he said, Jeff, if you could map the entirety of human history onto one day, we lived communally for 23 hours and 54 minutes of it.
Wow.
And our engineering evolves in relationship to our environment. So it would make some logical sense that we are truly actually wired for this kind of social connection. Does it actually influence the expression of our genes? I don't know enough about it, but I think it's an interesting concept.
I wouldn't be surprised if we know everything else influences how our genes act. I obviously the food we eat, how much we move, our thoughts sometimes. I wouldn't be surprised if that does. And I wish we would just kind of go back to like having like little commune and having your family or your friends and your mother and, all those people in one spot. I miss that, even though I was never really a part of it.
Yeah, yeah. I often think, kind of amidst the deluge of information around health, that one simple way of answering a lot of questions is just seeing choices through the lens of how did I evolve, right? Because evolution is so slow. Essentially our genes are more or less exactly the same as our hunter-gatherer ancestor genes, right? But culture is incredibly fast to the point where culture has now, in many ways, hijacked our own genomics. and uses it against us. And so that's often when people are very confused around health. I say, just ask yourself this question: how did I evolve? And try to answer through that lens.
Yeah, it's a great way of thinking about it. I think how, the way we move, the way we eat, the way we, certainly our ancestors didn't have everything right, and they weren't as perfect as I think that we kind of
Yeah.
idealized their lifestyle at sometimes. But I think that there are certainly things they were doing a lot better than we're doing.
Yeah. There was no vaginal estradiol back on the Serengeti.
There was no vaginal estradiol. That's true. And in fact, one of the humans are one of the only mammal species that go through menopause, where you stop making vital hormones like halfway through your
Mhm.
life, and there's a lot of questions about why we've evolved like this, and one of the big hypotheses is called the grandmother hypothesis, which is essentially that they wanted women, once they got to be 45 or 50, to stop kind of competing for partners with their daughters, and instead to become infertile and also maybe less energetic, and so they would just stay and take care of the grandkids while the younger people could go out and mate and make more babies and things. So it's interesting to think about why are we programmed like this when nobody else is in the mammal kingdom.
Yeah, it's interesting. I think there's a few species of whales, maybe, but
Yeah.
yeah, I think the grandmother hypothesis is interesting, and it might relate to sort of this protracted period of helplessness that human babies actually go through, right? So then you need additional caregivers, and that old adage, it takes a village to raise a child or whatever, it did actually truly apply for much of human history. And so to actually have a certain cohort of the tribe that was there to raise children, that seems adaptive on some
Yeah.
level. So
Also,
yeah,
I would argue that if you feel miserable, which a lot of women do when they kind of get into menopause without estrogen, if you feel tired and unmotivated and achy and sore and like all the things that happen, you're probably not as good a caregiver to those grandchildren as you could have been.
true, true. So what's your kind of short term and long range mission as Dr. Amy Killen right now, kind of within your professional life?
So I have a couple of different companies. I have a longevity clinic, Humanot, which is in Austin, in Florida, and I also have a supplement brand for women called Hop. I'm writing a book about women's longevity right now that just got picked up. It's
Amazing.
official yet, but it's kind of official. And so it's funny. I treat men and women in my practices, but over the last few years, I've become laser focused on women's health and women's longevity and kind of how we can do better, because as you mentioned, so much information that's out there is for men, and or just kind of, it's just not, we don't know if it's for men or it's just kind of there. And so women are such different creatures that I want to make it more available for the information for women to know how to be healthy, and for all of us to kind of learn from each other.
Amazing. And when should we be looking out for the publication of said book?
It won't be
Not to
till
put
2027, so you got all kinds of time.
not to put any pressure. I know the gestation of books are longer than the gestation of children, if you can imagine.
Yeah.
Have you started on that manuscript yet?
Yeah, I've started. I had to submit, 3 chapters and the outline and all that to the different publishers before I met with them. So I have gotten started. I actually wrote almost the whole thing first, realized it was way too detailed and too deep and boring. And so now I had to pull back, and I'm rewriting it. So hopefully it'll be a little more interesting than that first draft.
Yeah, well, I'm sure there'll be probably a draft out there for the people with letters at the end of their name, and then there needs to be a draft for laymen, or citizen scientists like myself,
Yeah.
who need simplified terminology.
I feel
So,
like you're not so much a layman. I feel like you know as much as most doctors, or more than many doctors do.
well, yeah, trial by fire. It's mostly out of fear of embarrassment in being in conversations like this and not knowing what I'm talking about. And I still manage to step in a bucket of poop quite often, so don't worry.
But that's all.
Well, I deeply appreciate how you move through the world. I think you disseminate a lot of information with a tremendous amount of clarity, but also with a bit of levity and humor too, because I think we all need a laugh right now, given the times. So thank you for everything that you do, and I hope that we can have future conversations here on Substack and hopefully in four-dimensional space-time as well.
Yes, thank you so much. It was great talking to you today.
Cool.